series of the Medical Center Hour. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities, and we bring you this series pretty much every week now, every week now, until April the 10th. So welcome, and we hope to see many of you here throughout the semester. Our program today is called The New MCAT and Doctors for the 21st Century. With implementation of the Affordable Care Act on the near horizon and other social realities such as aging and immigration and quests for prevention and wellness, all these things changing healthcare in the U.S., what kinds of doctors will our healthcare system and its patients require? Clearly, not just medical school curricula, but also the selection of medical students will be key determinants of whether the next generation of physicians is fully prepared to practice as the 21st century unfolds. In our program today, we address transformational changes afoot in the pre-professional preparation and selection of medical students. We're focused on the new version of the MCAT exam, which goes live in, I believe, 2015. What does the new MCAT signal for students preparing for medical school? How might the new exam's areas of emphasis in turn influence the qualifications that medical schools seek in their applicants? And how might this inflect schools' selection of students? Perhaps less obviously, but no less momentously, the new MCAT represents an important opportunity for colleges and universities, especially those like UVA, which have many, many pre-medical students among their undergraduates. How might such schools redesign their curriculum to offer the pre-med cohort academic experiences that will better prepare them for medical school and medical practice in the coming years? Here to weigh in on these questions are three distinguished speakers. We welcome two UVA faculty members as respondents. First, in the middle, Dr. Randolph Canterbury, who is the Wilfrid Spradlin Professor of Psychiatry and Neurobehavioral Sciences, Professor of Medicine, and Senior Associate Dean for Education here in the School of Medicine. Our second respondent, on my near right, is Professor Michael Levenson, William B. Christian Professor of English, and Director of UVA's quite new Institute for the Humanities and Global Cultures, an organization which is also a co-sponsor of today's program. And we're very proud to welcome from Washington, D.C. as principal speaker, Dr. Darrell Kirch, President of the Association of American Medical Colleges. Vice President and Dean of Medicine, Stephen Dukoski, will introduce Dr. Kirch. And let me quickly say that none of our speakers declared any financial conflict of interest.
On behalf of the School of Medicine, I would like to welcome all of you to today's session. It's my pleasure to introduce Dr. Darrell Kirch, who is a longtime friend and president and CEO of the AAMC, the Association of American Medical Colleges, which is the organization that represents the medical schools of the United States, teaching hospitals, and academic societies. Dr. Kirch is a distinguished physician, educator, and medical scientist, speaks widely on the need for transformation in the nation's healthcare system and how academic medicine can lead that change, especially in the education domain, in medical research, and in patient care. Prior to becoming the head of the AAMC in 2006, Dr. Kirch served as the Dean and Academic Health System leader of two health systems, the Medical College of Georgia and the Penn State Milton S. Hershey Medical Center in Hershey, Pennsylvania, the Penn State Medical School. He has co-chaired the Liaison Committee on Medical Education, better known to us as the LCME, which is the accrediting body for United States medical schools, and he now serves as a member at large on the National Board of Medical Examiners, the NBME, and is chair of the Department of Veterans Affairs Special Medical Advisory Group. Dr. Kirch is also a member of the Institute of Medicine of the National Academies. He is a psychiatrist and a clinical neuroscientist by training, and he began his career at the National Institute of Mental Health, NIMH, and became the acting scientific director in 1993. He received the Outstanding Service Medal of the United States Public Health Service. He is a native of Denver, Colorado, and for those of you smiling at the weather, received both his BA and his MD degrees at the University of Colorado. It's my great pleasure to introduce Dr. Darrell Kirch.
Thank my friend Dr. Dukoski for a very kind introduction, and I've known him in recent years mostly through our interactions in his leadership on the Council of Deans, but I've also made periodic visits to UVA. My daughter was an undergraduate here and then got her master's at the Curry School, and I've seen the mark of Dr. Dukoski's leadership as the new medical education building opened, as your new curriculum, which has gotten lots of national recognition, as your program in faculty development, and in fact developing faculty satisfaction has advanced, and it's really been a pleasure to watch. I don't have any conflicts of interest. I do have an interest, though. As an aging baby boomer, when I think about the doctors of the future, what I think about is someday it's going to be me in the gurney or the hospital bed or on the operating room table looking up at one of you and hoping you are a certain kind of person, a good doctor. Now, to talk about selecting those good doctors and to talk a bit specifically about the tools like the MCAT we use to select those doctors, we do need, I think, to keep things in context. We can't consider all this independent of what we're trying to do in healthcare writ large in the United States. The healthcare reform discussion that has been at times so painful and is so momentous is not really just a product or idea of this man, our president just elected to a second term. It goes back a long way. Dr. Dukoski has a door prize for those of you who can identify this man. Oh, you get to keep the Mercedes. That's Otto von Bismarck. Not exactly a radical left-wing liberal, but many consider him the father of modern healthcare insurance expansion. He advocated for healthcare insurance for all back in Germany during his time there. And U.S. presidents, LBJ and Medicare, Nixon, and the introduction of HMOs, there have been interest in both parties in reforming healthcare. It's just that we finally have seen more action than at any point in the last 50 years under President Obama. It was nip and tuck right up until July in that momentous Supreme Court case decision that was announced in July. It was close, but here's Chief Justice Roberts issuing his decision. It was as narrow as it can get, but the declaration that it's constitutional is now allowing implementation of the Affordable Care Act to move ahead. So why do we still see headlines like these pulled down in just the last week or two? The concern is still there. The ACA, as much as we'd like to view it as a step forward, is an insurance bill. It is basically focused on expanding insurance coverage, which is necessary to make a healthcare system work. But it doesn't do anything about healthcare outcome problems like the obesity epidemic and the related diseases of diabetes. It certainly doesn't tame the healthcare monster, which in this case is spending, and the fact that we're rapidly approaching $3 trillion a year, and that for that $3 trillion a year, which may or may not be slowing a bit, we have among the worst outcomes in the world. I travel internationally, and I can be in Europe or Japan, and sometimes my colleagues, medical school deans and others over dinner, they're always more diplomatic than this, but they'll look at me and say, how can you stand it? How can the leaders of American medicine sit back with some of the poorest statistics around things like infant mortality, life expectancy statistics, so subpar, spending all that money and not achieving the kind of value that better outcomes would reveal? So the problems are still there because what we haven't done while we've expanded insurance, is we're still a long way away from achieving what Dr. Don Berwick, wonderful thinker, advocate of quality and safety, and for a period the head of the Center for Medicare and Medicaid Services when the ACA passed, but Dr. Berwick calls the AAA. And what we're seeking is a system not only where there's better care for individuals. It doesn't mean just people like me who are haves in the healthcare system. He means for people who've historically been the have-nots, left out of the healthcare system. Where we have better health for populations, where Dr. Dukoski or any of us can travel to foreign countries and be proud of our outcomes. And where the costs are manageable, where for those of you under the age of 30, we're not mortgaging your future to pay for my Medicare costs. That's the AAA, and that's the kind of system we're headed toward, hopefully, with now expansion of insurance, helping us to some degree, especially bringing more access to a lot of the individuals who were out in the uninsured cold before passage of the ACA. So, it's pointed us in the right direction. But there's a lot to do, and what I want to focus on in the next few minutes is what I think may be the rate-limiting factor about getting there. I can picture what the system should be. I know what a quality system would look like. The question is, who's going to create it? It really is, what will the workforce be that can actually achieve the kinds of goals that are outlined there? That is a huge question. It's a question, first of all, of numbers. We probably, in view of most people in Washington and beyond, have the most credible data in our Workforce Studies Center about the physician workforce. We have basically, through a combination of circumstances we can get into, but in particular because of a limited amount of funding for residency training slots, we are projecting virtually no growth in the supply of physicians in the U.S., but the demand will go up. Why will it go up? Well, how about 10,000 baby boomers turning 65 every day now? People entering periods of life with higher utilization. How about those baby boomers living longer? How about new emerging treatments that scientists at UVA and elsewhere are developing? All of that will push the demand. Now you might say, and every physician audience I speak with or health policy audience says, well, what if we did this? What if we used more nurse practitioners? Or what if we used more telehealth technology or other tools? We run as many equations as we can imagine about what the variables around the workforce might be. And while the numbers of different sets of assumptions do range, that range is all here. There is no set of equations we've been able to run that shows us having a workforce physician surplus. So we've got a numbers problem to start with. And it hasn't been the medical schools. The medical schools in the U.S. have actually increased their capacity. The problem is we've not been able to have the national discussion, especially with Congress, about increasing funding for residency training. But you know as well as I do, we could train an increased number of physicians, but if we train them all to work in the dysfunctional system we have now, the system that doesn't achieve the AAA, what's the good? So it's not just the numbers of physicians, but it's who we select and how we train them. And I would argue, I think the focus of our discussion today is the first critical step in this whole process, the process that will determine who is the doctor looking down at my bed, my gurney, is admissions to medical school. It sets the whole process of becoming a physician in motion. So how are we going to transform admissions so that it can be this critical success factor in producing the physicians for the triple aim system? Well, we all have an image of the good doctor. This is the famous painting by Sir Luke Files that hangs in the Tate, I think, in London. And I think it captures on a very visceral level the image of what each one of us would hope our doctor would be. The really sort of focused, all-caring person who, despite the perplexing problem of the patient in front of him or the grief, the suffering of the family standing on, has his or her total focus on that patient. We've had this kind of iconic, vague image of what a good doctor is. But that was a century ago. Where are we now? Are we clear on our image of the good doctor? I would argue that it's not Dr. McDreamy or Meredith Grey. I have watched a few episodes of Grey's Anatomy. I watch it solely to count the number of ethical violations. But all humor aside, we've developed a public image of medicine that seems to be all over the map. To get much more concrete and specific about it, when we do public opinion polling and ask patients, just ask the public, how confident are you in our graduates, not just UVA graduates, but all the U.S. medical schools in terms of their medical knowledge, how much they've learned about medicine? Those are great numbers. It's pretty hard to get 85% of Americans to say they feel good about anything. They're confident in our medical knowledge. When we ask them in the same polling, how do you feel about their bedside manner? Which I would argue is a kind of catchphrase surrogate for all the qualities embodied in that painting of the doctor by Sir Luke Faust. When we ask them that, these numbers are not nearly as good. That's very disconcerting that a third of patients are saying that they believe that the physicians out there that we've trained are only fair or poor in their bedside manner. Well, we have been studying this in recent years. We have engaged faculty members, people on admissions committees. I would bet there are some people here who serve on the UVA's admissions committee. We've engaged people to say, so where are we going wrong? What is it that we've been doing or not doing that has led to a production of doctors where there's confidence in their knowledge, but much less confidence in their, let's use the word professional, broader professional skills. And the consensus that emerged is that what you know is only part of being a good doctor. How many of us have seen a doctor who's brilliant, but you don't feel you can relate to them? You don't even feel comfortable asking a question of that physician. Personal characteristics, experience, attributes are important. They're definitely important. And what about diversity? There is a mounting literature that says that diversity is not an issue of numbers or percentage of representation. Diversity is a key element of excellence. The research base is actually so compelling that if you take an individual and give them a problem, give the same problem to a team, the team comes up with a better solution. If you give the same problem to a diverse team, they come up with an even better solution. Diversity is a key to producing the kinds of physicians that we want and need. But under the heading of confession, true confessions, the AMC, among other things, runs this little examination a few of you may have heard of called the MCAT. And the MCAT becomes such a dominant, almost tyrannical force in the thinking of pre-meds. Do I hear an amen from the audience? In the thinking of pre-meds, that I would argue it unbalances the equation here. And that it may cause people who bring a great deal to the table in these other two areas to say, I guess medicine isn't for me. So how are we going to get there? What is the transformation? And I'm going to walk you through quickly the schema that we're using. Not, the AMC can't do this. We can only do it in partnership with faculties like the faculty at UVA, but also importantly with universities, because it's the universities in their undergraduate programs that set the stage for all this. How are we viewing thinking about this in the future, starting now? This is on the list of references you were given, and it was a piece I was privileged to write for the Journal of the AMA in their medical education issue. talking about how we have to transform admissions. I actually was commenting in this piece on a technique I'll refer to a bit later around interviewing applicants. This is what admissions works like, right? In the ideal world, you'd look at those 3 dimensions I talked about, you know, preparedness to learn the factual material, these personal qualities, and diversity. You'd wrap them together in a holistic process, and you'd do admissions. Again, I would argue, though, this circle, in reality, historically, has been huge, and these we've struggled with, in part because of our inability in this area to have good tools to measure. So, our goal is to create a balanced admission system that looks like this, with those 3 key words embedded in there, and where there is a roughly comparable assessment of each of the 3 dimensions in admissions. Now, looking at them individually, academic readiness, the MCAT is not going to go away. You cannot put people through the rigors of medical education without knowing that they can handle the cognitive level of the work that's there. The question is really, though, how you structure the MCAT. We had a wonderful group of people, about 30 of our medical school colleagues from around the country, who spent 3 years struggling with this issue. They debated, you know, can we just give up the MCAT? Should we rely on SAT scores? You know, just give an IQ test. They explored every option. They said, no, we need a baseline test to assess cognitive capacities, but it could be a much different test than the one we have now. And this was the result at the bottom of their discussions. Yes, you still need to understand basic biological concepts, basic quantitative concepts in order to master medicine, right? So there are natural sciences sections remaining in the MCAT, although they're less tied to traditional courses, 2 semesters of general chemistry, 2 semesters of organic chemistry. You get to synthesize an aspirin in lab, and then you know everything there is to know. You know, possibly there's a different way to approach the natural sciences. But this was, for me, as a psychiatrist and neuroscientist, and as a physician who understands your social situation is as important as your DNA in determining your health. The section adds social and behavioral sciences to the mix. The writing sample, which did exist and which was routinely ignored by admissions committees, will be gone. And instead it will be replaced by a section that tests the way people reason on passages. And those passages won't be passages from organic chemistry texts. They'll be ethical dilemmas. They'll be philosophical questions. They'll be designed on social issues in order to assess critical thinking skills. But it will be a challenge. That's why the official start date for the new test is 2015, not just to develop it, but to start to give people time to rethink pre-medical prerequisite courses for medical school, rather, to give people time to think about, are there new alternative ways that we can approach undergraduate education to prepare people for this broader view of medicine and healthcare? If you're curious about it, this actually was just released. It talks about the MCAT now and the MCAT in the future and how we're going to be designing it. All these materials are available from our website, can be pulled down. I wondered about whether this would get noticed at all. In my now nearly 7 years at the AMC, there's been more press attention to the MCAT change than anything else we've done. And this was my favorite headline, Humanizing the MCAT. The public has responded to this. They really see this as trying to rebalance the equation. And it's important for you as a doctor to know about my social situation as it is to know, what my genotype is. Moving to the other dimensions that are so important, pre-professional readiness is tough to assess. Who are you as a person? I'm joined today by my wife, Dr. Deborah Kirch, who's on the faculty at GW and over the years has served on interviewing applicants at 3 different medical schools now. And it's kind of tough to get a full picture of a human being in a 30-minute interview. In some schools, there may be 2 30-minute interviews, so one of those interviewers may be a surgeon who's really thinking about the case they just left in the OR. It is not the best assessment of pre-professional readiness, but now new tools are emerging here. The article I was commenting on in my JAMA paper was actually a review of the now dozens of schools doing something called the multiple mini interview. The technique that's in use in a lot of US and Canadian schools, where instead of the traditional sit down and tell me about yourself interview, students move from station to station and may be presented with actually scenarios, standardized scenarios. Or they may be presented with a standardized question and a kind of structured interview following that. But it can go beyond this. Letters of recommendation have been historically often so vacuous. You know, I don't really know this applicant, but I know their parents, and they're really nice people, so this must be a person, should be a good doctor. You could literally see letters that were as devoid of content as that. What about letters of recommendation in which the requirement is that they be structured more like a 360? Give me specific examples you've seen of how this applicant demonstrates these qualities. So there are a number of tools. One of the ideas that is being kicked around, if you could do it in the right way, is instead of having every school have to do its interviewing from scratch, what if we structured a way using Skype or a similar tool of doing a structured interview nationally and having reports then included with the applicant's files so that people could get a kind of first interview screen to look at. So there's enormous potential here of trying to add content on this dimension. What are the qualities? Again, those same groups that have worked on the MR5 process and others I'm not saying this is an exhaustive list, but if you read that list of interpersonal and intrapersonal qualities, isn't that what you want from the doctor caring for you or the people you love? Aren't those the properties you're counting on? So our challenge is to use the interview process, letters of recommendation, the application itself. The MCAT application will change. You know, there may still be a free-form personal statement, but I think we will be challenging applicants more and more to say, give us an example from your life in which you demonstrated resilience and adaptability, for example. Lastly, going to diversity, I'm worried. I'm worried because the Supreme Court is, much to everyone's surprise, after not too many years ago, affirming the importance of diversity in higher education in the Grutter case, has taken up another case from the University of Texas, Fisher versus Texas. There's a lot of concern that there will be further constraints placed upon universities, medical schools, and other higher ed institutions in terms of their ability to entertain considerations of diversity in the selection of students. This is actually the brief that we took the lead on filing in the Fisher case, in which we make what I think is a very compelling argument that the United States as a nation is rife with health inequities. And those health inequities track with socioeconomic groups, racial and ethnic groups, and that unless we have a culturally diverse, racially and ethnically diverse workforce, we're never going to be able to really start to approach and resolve those inequities. That's the argument of our case. Actually, our brief in the Grutter case was viewed as one of the determining briefs. We can only hope it carries some weight this time around. All of this then gets wrapped together by, I used to, when I was dean, I used to tell the people on the admissions committee, there was no question in my mind, it's the hardest committee assignment on the university medical school campus. You have so many fantastic people vying for a limited number of places in a medical school. We want to help them do holistic review by wrapping tools around the process that will facilitate it. This is a report, and I think actually at one point the team that we have that works with admissions committees has come down to do a session where we basically have a SWAT team that visits campuses to work with admissions committees to learn how to shift toward a more holistic approach in their admissions reviews. So that's the process. And this is the paradigm shift. You can read through this. There's nothing on here I haven't already talked about. This is the way we've often tended to look at those applying to medical school in the past. Did they take the courses? What was their MCAT score? And so on. This is the approach we want to shift to on the right. So it's not what your grade was in a specific course, but it's can you demonstrate. For example, calculus was not my most favorite course. And in hindsight, I actually think the quantitative competencies I would have developed in a rigorous statistics course would have helped me more in science and medicine. So the items on the right reflect what we hope will be the view of the selection in the future. This is only the start of it. Okay, we've talked about today is really this transition point. But it sends a signal, we hope. A signal that we really are not just trying to recruit people with great MCATs who will do well in the first year or two here, but what we're really focused on is the people who will do well out here. And we also hope it's a signal headed this way. You know, I actually was not a science major, I was a philosophy major. When I leave the AMC, I would love to teach an undergraduate course in the ethics of healthcare and the health system in the United States to undergraduates. I think that we desperately need undergraduate courses in social and behavioral determinants of health. I think we need courses in health literacy. You know, I'm on the board of the American Council of Education. I had one of my research associates look at the general curricular requirements. There are still many prestigious universities in the United States that have a general education requirement for your bachelor's degree that includes phys ed, but we couldn't find a single one that had a general education requirement for health literacy. Because the courses don't exist, really. What should any college-educated individual understand about healthcare? There are enormous opportunities here, and this isn't all theoretical. You know, in the end, you and I'm closer to it than almost all of you, are going to need someday to have a high-performing interprofessional team, a team that demonstrates all those intra and interpersonal qualities to take care of us. We hope we're sending a signal about the direction we need to go. Thank you.
Thank you, Dr. Kirch. It's a pleasure to be able to respond to Dr. Kirch's comments. After serving for 8 years as the admissions dean, I do have a little bit of insight into this. In the last few years, more focus on curriculum in medical school. I'd sort of like to tie those together a bit if I could, and move a little beyond the MCAT. But the MCAT has done a great job of doing one thing, telling us how well medical students are likely to do in their first 2 years of medical school, how well they're likely to perform on the first step of the medical licensing exam. It has high predictive validity in that regard. The reason for that's pretty simple. The current MCAT is pretty much structured like most of the exams that are given in the first 2 years of medical school, and structured much like the first step of the USMLE. So you would expect those students who start with good scores on the MCAT to continue to have good scores on similar kinds of exams. The medical education is changing quite a bit, changing dramatically, in fact. There are a lot of reasons for that. One of the reasons is that I don't think we're just learning how adults learn, but in fact we're starting to recognize that we have a lot of literature on how adults learn best, and particularly something as complicated as medicine. We're also being driven to change curriculum in medical schools by changes in the medical licensing exam, which we're going to see within the next 2 to 3 years. and also the accrediting body, the LCME, is driving us to change. So I think it's probably fair to say that every medical school in the United States is in a process of some curricular change. I want to say a few words about what we've done at the University of Virginia in that regard, and then tie back to how the MCAT 215 may be helpful in that. At UVA, our curriculum reform started in 2008, and it was very well received by faculty and students alike. That was a joke. Nobody ever wants to change. First of all, nobody thinks you're doing a bad job, okay? And in fact, people weren't doing a bad job. They were doing a perfectly fine job. They were just doing things differently from the way they seem to need to be done in the future. At any rate, we called our curriculum, our new curriculum, the Next Generation Cells to Society curriculum. We began planning it in 2008. We implemented it in August of 2010, a very aggressive timeline. And we have been successful, I think. It's in its third iteration of continuous curricular improvement, which is something that we'll be doing forever, I hope. And things are going pretty well. So what are the differences between the new curriculum and the old curriculum? Well, the Next Gen curriculum really is based on a number of different principles. One of those principles is that everything that we teach really needs to be foundational to clinical medicine or clinical medicine itself. We're not teaching the sciences in isolation anymore. We're integrating them into the care of the patient. We are trying to teach medicine or teach the sciences in the context of how students or physicians will be using that information. Big change from the way the discipline-based courses have been taught in the past. Another thing that we're doing is changing pedagogy. And historically, most of the curriculum at this medical school and most others was in the form of lectures that the faculty gave to students. So the students played a fairly passive role. They sat, they listened, they hopefully absorbed, then they went home and memorized it all, and then they came back and regurgitated on the exams, and they did very well because the exams were just like the MCAT that predicted the way that they would perform. And so today, we've tried to change that quite a bit. We've changed the paradigm a lot, in fact. We define the students' learning objectives very carefully, tell them exactly what we expect them to know, very precisely. We have over 7,000 of those, by the way, in the first 18 months of our curriculum. So the students are expected really to come to the classroom having prepared the knowledge portion or the cognitive portion of their learning. In the classroom, with the faculty, we hope that they will be challenged to a higher level or deeper learning, and not just memorizing facts, but also learning how to apply those. How to analyze, how to synthesize information. That is, in fact, what physicians are challenged to do every day on a daily basis as we interact with patients. Every patient who comes into the office represents a new challenge, a novel situation. We have to take all that we know, apply it to that specific situation. And so that's what we're asking our students to do in the classroom. We still continue, of course we continue to teach the foundational sciences. For example, we still teach the biochemistry of DNA. That's pretty important stuff. It's not just important stuff for the physician because it's interesting information or it's the basis of life, but it's important because it's foundational to the understanding of a disease like cancer, its pathogenesis, potential treatment strategies, and so forth. We continue to teach anatomy, which is a basic science course, but we don't just teach it from the perspective of dissection anymore. We have a higher expectation. Physicians don't dissect cadavers normally, but what they do is look through the eye of different kinds of medical imaging. So anatomy is taught not just with dissection, but also taught with MRI, CT scanning, etc. And so again, the information is being taught in the context of how it's going to be used by physicians. But simultaneously, in addition to learning this kind of information, students are learning a lot more. They're developing their clinical skills, which includes patient interviewing, communication skills, physical examination skills, physical diagnosis, clinical reasoning and presentation skills, and so forth. Most of that's done in small groups We have one faculty mentor paired with 6 medical students. They develop a pretty intimate relationship, meeting for many hours a week over an 18-month period. But that's where they're learning to be doctors. They do that by practicing on each other sometimes, also simulations, whether that be standardized patients or medical simulations, or a variety of computer case simulations and so on and so forth. This year we're actually introducing, or we're about to introduce, virtual patient technology, which allows students to practice interviewing skills over and over again, organize information about a virtual patient, and in fact present it in a written note kind of format, which they then can compare to a standard from experts, so they can learn how to develop those skills and do it really in their leisure, because it's a virtual patient. They never get tired. Hopefully. All of this learning is designed really to help our students have a seamless transition into clerkships, where they will continue to learn clinical medicine at the patient's bedside. So that is the goal. By the way, in addition to all of this that they're learning, they also are expected to be learning epidemiology and biostatistics, so they can be lifelong learners, be able to review the medical literature in a critical way. They're also learning the principles of biomedical ethics and how they apply to patient care. We're also hopefully modeling professionalism and teaching professionalism. What is it like to be a physician? What are the important characteristics of a physician, some of which Dr. Kirch pointed out. We start on day 1 of orientation, teaching them what it means to be an effective team member, how being a good team member means giving and inviting feedback, and in fact, doing that will result in better clinical care and a reduction in medical errors. We also want them to understand that there are many individual and cultural differences within our patients, and that understanding those really are critical for being able to provide excellent health care. Our expectations of our students are extremely high. They are a bit different from the rote memorization of the past, but still very high. And the metaphor of trying to sip water from a fire hose is still applicable to medical school, no question about that. So in all this change in our medical education paradigm, you might think that students would be enamored by it. They are. They say they love it, and that they would come and participate very actively in the classroom. Historically, only about 40% of students came to medical school lectures. And by the way, now students still are reluctant to come. And why is that? There's a reason for it. The reason is very simple. Despite the fact that we have put all the energy, effort into improving the curricular experience, we continue to assess them. We still give them the same kinds of exams that we gave them in the past. Basically fairly low-level, multiple-choice recall exams. And what they've learned is that they can be much more expeditious by staying at home or sitting in the library, memorizing facts, rather than learning a higher level of medicine, because that's what we're testing them on. So my mantra for the last couple of years has been that assessment drives learning. And I believe that in the core of my existence, okay? That whatever we test the students on is exactly what they will learn, even if they recognize that they ought to be learning more. To learn more would be more important for them to be better doctors. So you might imagine that we have changed our focus from changing pedagogy today, and we've done a lot of that, to a focus on assessment. We really want to elevate our assessments using clinical skills assessments primarily, or clinical reasoning assessments, so that students, in fact, will recognize the direct benefit on the assessments of being in the classroom and participating in those kinds of activities. So what about the MCAT 2015? I am encouraged. I'm always an optimistic person, but I think that the MCAT 215 will assess students' experiences in the cognitive domain with things way beyond the original MCAT. It's not going to be just the sciences. It's going to go broadly to sociology, to ethics, to psychology, and so on and so forth. I think that's a very important thing. What it probably won't assess is the interpersonal skills, the communication skills, and so forth, as Dr. Kirch pointed out. The medical school interview will continue to be there, whether it's the MMI that's being adopted by so many schools or a more traditional interview. We've not yet adopted the MMI. We've reviewed it several times. We've had discussions about it. But what we've been doing seems to be working. We're going to go back and revisit it again. We will continue to do that. So objectifying the interview might be a good thing. Just a couple more comments. In the near future, I think we're going to be seeing that whether or not the MCAT 2015 works. It'll take a few years of acquiring data. I know that some of it's going to be embedded in the current MCAT so that it can be assessed early, but it'll take a few years for us to be able to correlate it with performance in the new curriculum in the medical schools. But I think that changing the MCAT really is very important because it will drive what the students are doing as undergraduates, just as it drives what they do in medical school as well. If you don't believe that, I'm running over time, so I'm going to stop. You should listen to what Dr. Levenson has to say because colleges all across the United States already are talking about how do we change the undergraduate curriculum in order to accommodate what medical students will need for admission to medical school.
Hi everyone. I was flying back home yesterday. I was in Europe and just getting out of the snow and had two things to read on the plane. I was reading Dostoevsky's great novel, The Idiot. I was reading the newly released guide to MCAT 2015. And wow, it was a crazy flight. I was back and forth between the two. You can't read Dostoevsky for too many hours in a row on an 8-hour flight, so it's good to have MCAT 2015 there too. I'm new to it. Long ago, I was a pre-med English major, and I came to the forking of the ways. And they forked, and here I am as a professor of English. I think I'm representing the humanities on this panel. And what I found reading through the new official guide is that it's a very strong and promising step. But I found that I wanted to come here today and say what Dr. Kirch said. It's only the start of it. And I wanted to say that it's a great start, but even before it begins, we can talk about how it could go further. I am committed to the humanities, especially these days to the global humanities. That's my thing, my vocation, my life. So first to the global. I read, Dr. Kirch, your nice little piece in JAMA, and you may not remember, but at one point you say, and students will be encouraged to look at cross-cultural matters. Do a search. You can do this on your PDF, on the new official guide, 158 pages. You find the word cultural. You don't find the word cross-cultural. You find almost no attention to the transnational, the international, or the global. Now, I think it's a good turn to ask students to take Introduction to Sociology and Psychology, to look at social and psychological determinants of behavior, to learn something about theories of functionalism and peer pressure and stigma and deviance, theory of the emotion and identity development. Notice that it's not anthropology that's the introduction that's being put in place. That's interesting. Anthropology is a more unsettled discipline. There's a question of whether it counts as a science in the way that psychology or sociology might do. But what anthropology would have given was exactly that attention to the comparative, the international, and the global. We all know, you all know, that your future is global. It doesn't matter what you're doing. Your future as clinician, as researcher, is going to be involved with work in other places, research in other places, people coming from other places, you're going to other places. Medical students are going to have to open themselves up to the global turn. And that's just a point that I want to take out of my reading yesterday on the plane of the new guide, that there's so very little attention to the global in this projection of what students will be trained for as they approach the MCAT. I don't blame anyone. I just think it's interesting, and I think it's going to be worth talking about. What is the place of that concern in the creation of a new generation of doctors? Global and now the humanities. The new exam will have a section, Dr. Kirch talked on this, the last section will be on critical analysis and reasoning skills, and I plucked out a passage that I can read to you. This is the only context in which the word humanities appears in the guide. The critical analysis and reasoning skills section asks you to analyze, evaluate, and apply information provided by passages from a wide range of social sciences and humanities disciplines. It does not require specific knowledge of these disciplines, but it tests the analysis and reasoning skills you need for medical school and may prompt you to read broadly as you prepare. Along with many others, passages about ethics and philosophy, cultural studies, and population health are included. So there will be passages from these rich content disciplines, for example, ethics and cultural studies, but specific knowledge is not required. From my perspective, this is pretty interesting. It's a kind of interesting, I want to say, sleight of hand. The test promises that it won't require mastery of history, religious studies, philosophy, fine arts, English. The passages will make references to those fields. That's the sleight of hand. There's a sample question. It's around page 142, I believe. It gives a passage from a new book on India. It's an interesting passage. It's complex. It requires a lot of attention to read it through properly. But you don't need to know anything about India to answer the question. What you need are good critical and reasoning skills if you're going to read that passage well. Critical reasoning is great, but so is the knowledge of India. The humanities have a content because humanities has content. We have a particular history and culture. We have continuities and differences. Particular events and texts and artifacts have made us who we are. There was an industrial revolution. Plato told a parable of the cave. Confucian ethics came to dominate in China. In Latin America, Catholicism and social revolution went hand in hand. Picasso revolutionized painting not once, but repeatedly. Shakespeare's King Lear tells us more about humanness than current theories of identity development. These are not just ornamental and pleasant things to know. They are who we are. We are products of particular histories, which is important for doctors to know. There's 3 theories of emotion in psychology. One last thought. In order to be good for one another in the classroom or in clinics, we need to know what's possible. Not only what is actual, but what is possible. The humanities, the global humanities, offer possibilities that we deny at our diminishment. They tell us what people have felt and done and believed and tried. There's no mistake greater than assuming that we've outlived the possibilities in the past. Unless it's the mistake of thinking that our lives can be circumscribed by national boundaries and that other parts of the world are finally tourist destinations that we will soon be able to afford instead of what they are, sites of insight that we cannot afford to ignore.
Thanks so much, and I would ask you if you would quickly come up to the panel desk. We have a very few minutes for some questions, and we have a couple of medical students with microphones who will bring the mic to you if you have a comment or a question. I would ask that you please identify yourself, when you ask your question or make your comment. I think there was a lot to think about in these presentations, and we'd love to hear from you, even though we just have a couple of minutes. Yes, if you want to bring the mic and down to, there are a couple of hands, right?
There's one right here.
Oh, okay.
In the back row.
Okay.
It's Kevin Lee, I'm from neuroscience. Dr. Kirch had mentioned providing some lead time to think about how to implement these plans for the 2/15 start date. And I was trying to think of the students that are enrolled now. This year will be taking, the undergraduates taking the MCAT as juniors. They're already in school, right? So has the AAMC given guidance or some advice to undergraduate programs for those students that are already engaged in a set curriculum, how they are going to modify their plans for the next couple of years to be prepared to take the MCAT in 2015?
You know, we've really actually, because we gathered data in the application service about the specific undergraduate experiences of applicants, it's striking that I think the MCAT 2015 is, in many ways, is just acknowledging what students are already doing. Over 70% of matriculants to medical school have taken one or more courses in psychology. Sociology ranks very high. The percentage of students who've done global experiences of one kind or another is very high. So I think almost in a sense we're following the students. What I think will change, and already is changing when I advise pre-medical students, is that essentially they're being given greater permission to follow their passions, to not ignore that there are certain scientific foundations that you need to establish credibility in, but that it is okay and valid to pursue a passion in any field, you know, medieval French literature, and that your mastery in that area only broadens you as an individual and as a potential physician.
Do you envision a role for medical school faculty to assist in that process?
Oh, I think medical school faculty, for example, this concept of general ed courses on health literacy. I think medical school faculty, family physicians are wonderfully positioned to talk about the social and behavioral determinants of health at an undergraduate level. And actually there are a lot of institutions where there's a fair amount of cross-teaching of medical school faculty in the undergraduate curriculum, often teaming with someone else. You know, I fantasize about all the undergraduate courses I'd love to teach in. I'd love to find a political science who would, you know, a political scientist who would construct a course on the history, evolution of the U.S. healthcare system. So I think the opportunities are boundless, and the great thing is medical schools are, with very few exceptions, strongly associated with universities that have this wonderful breadth and depth that can be capitalized on.
Hi, I have two questions, but depending on time, I guess we can do one or something. But my main question is, how do you plan to, like you mentioned that you wanted to be able to pre-screen applicants before the interview step to understand who they are as a person, and I was wondering what steps you thought you could do that, because I think even if you change the MCAT to include other areas, it's still a score at the end that the admissions committee will see. Even though they will see the section breakdown, I think, like right now, for example, I feel like the verbal section isn't as valued as much as the science one, so how would you be able to encourage looking for the person beyond the numbers, even in that early step?
The area I was talking about that is still hotly debated is whether you could do a structured interview with trained interviewers, either who did this essentially full-time, do it either in person or via web technology, to basically get a sort of qualitative profile of the individual that would become added information to the applicant's file. The other thing is more and more students seek to demonstrate mastery in the humanities, and as we work on a better format for the letters of recommendation, I think it would be fantastic to take somebody who majored in one of your disciplines and ask a professor who knows them well to comment on what they saw that reflects that list of inter and intrapersonal characteristics. The last point I would make is I hope when I'm jet lagged, I'm as eloquent as Dr. Levenson.
I'm afraid we're at the end of our hour. Those of you who still have questions, you're welcome to come down front and ask them. We need to let Professor Levenson get some sleep. Thank you, and I hope you'll join us next week. We have a program. We have playwright Deborah Saylor-Smith from Providence, Rhode Island, talking about medical malpractice and forgiveness. Our respondent is Dr. Peggy Hughes-Owen from the Department of Medicine. And we'll have some actors here from UVA's Department of Drama doing scenes from the play. Thanks to our speakers for today.